Hi, thanks for joining this talk. I'm going to speak today about the National Quality Form UCSF CT radiation dose measure and how you can use this to assess your facility's radiation dose and performance. My outline for today is first to give you a little background on the National Quality Form, to give you some details of the UCSF measure in terms of why I created it and the measure specification, and then lastly how to use this measure as a starting point to assess the doses at your facility, or if you order studies, to start to ask that these doses be assessed using this measure at the facilities to which you send your patients. So the National Quality Form is a very interesting organization. It's a private organization that's focused on standard setting. Standard setting broadly on topics related to improving the quality of healthcare. It's a consensus organization, which means they have a lot of member stakeholders, and the stakeholders come from incredibly diverse settings. It includes consumers, health plans, health professionals, providers, health agencies, purchasers, suppliers, and industry. And my guess is that many of you belong to organizations that in turn are members of the National Quality Forum. They set priorities, and these priorities are generally voluntary standards that they're trying to get used to improve evidence-based practice. And they basically endorse standards for measuring and reporting on performance related to healthcare across a whole broad range of areas. In terms of where these measures come from, measures can be written by anyone with the time and the interest to do so. Often they're written by large organizations like CMS, the Center for Medicare and Medicaid Services, or professional organizations like the American College of Cardiology or the American College of Radiology, but they can be written by anyone. These measures have to be evidence-based, and the evaluation process that they use at the NQF for adoption of measures is very thorough. So they have to be acceptable in lots of different ways. There are lots of committees at the NQF, such as the Patient Safety Committee, and they determine for each measure that's submitted whether it's a valid measure, whether it's easy to be used, whether it's generalizable, lots of criteria they use like these. And if they believe that a measure has all of the requirements and could lead to improvements in performance or measurement or quality, then they'll adopt the measure. Once the National Quality Forum adopts measures, they can have a substantial impact on healthcare quality because lots of other organizations turn to the National Quality Forum for measures that will help them push quality forward. So I took a quick screenshot of the NQF measure webpage, and it's worth going to their website to get a sense of what measures are out there, and they span all kinds of different areas, and they're submitted by all kinds of organizations. And the measures don't have to be fancy. They can be simple measures. Measures like among patients who are admitted to a hospital with a heart attack, how many leave the hospital with a prescription for aspirin? Or they can be sophisticated measures where you have to use complex algorithms in the electronic medical record to assess compliance with the measure. As an example of some measures in the area of medical imaging, I thought I'd show you a handful of measures that have been adopted by NQF, they're endorsed by the NQF, around imaging efficiency measures. I happen to have been a participant in the committee evaluating imaging efficiency measures, and that's how I learned about the NQF. But here's a series of measures. How often is stenosis measured in carotid imaging studies correctly? How often is the probably benign category in mammography used inappropriately? How often are reminder systems in place? So that means, does a facility have reminder systems in place for telling patients that it's time for their next mammogram? What are the exposures times in fluoroscopy? And this is put in the patient's medical record. If patients undergo bone scans, have they looked at prior scans in those patients? The percent of patients who undergo cervical spine radiographs in trauma settings who do not have appropriate indications. The use of contrast CT for chest imaging. And if you look, for example, on Hospital Compare on the CMS webpage, you'll find this measurement calculated for each hospital in the country because CMS has adopted this measure that was endorsed by the NQF. And lastly, MRI lumbar spine imaging for low back pain and the appropriate use. So this is just a handful of measures in the area of medical imaging that the NQF has endorsed, and they have endorsed hundreds and thousands of measures. So in terms of the background on the UCSF radiation dose measurement, I felt strongly that if we had a standard way to assess facility radiation doses, that this would lead to improvements in practice, because it would give us a way to start having facilities look at how they're doing. I have actually worked with a large number of facilities where we have looked at the doses that they've used. And in general, when facilities look at the doses and understand their doses, they're inspired to do a better job and to improve and generally lower those doses. And I thought if we could come up with some standards that we agree with are a good way to start looking at facility performance, not a perfect way, but a good way to begin, that would lead to improvements in sort of dose awareness. How are you doing as a facility? And then strategies to improve it. So I was what's called the measure developer for this measure. It means I wrote the measure, and I reached out in the writing of this measure to a lot of content experts, people who have expertise in this area of dose measurement, radiation dose safety, to get their ideas for how to make the measure as good and useful as possible. My belief, and what I think can happen now, and I want to use the time today to tell you about this, is I think the data assembled using the NQF measure can be used both within your facility to understand how you're doing, as well as to compare across facilities, track facilities' performance over time, and assess dose in particularly important groups, for example, in young patients where the doses really matter. The NQF actually endorsed two measures of CT radiation dose at about the same time. One was the measure I'm going to tell you about, the UCSF CT radiation dose measure, and this requires facilities to assess the doses you use on consecutive patients as a way to know how you're doing. And the second measure was a measure put forth by the American College of Radiology, and to comply with that measure, you participate in their dose index registry. I think each of these NQF endorsed measures provides an opportunity to assess the doses that you use, and I'm going to talk about the first measure for the rest of my time. So the UCS dose measure, and I should say all of you can go online and read about the measure. We have information on our website for the meeting that you can learn about it, but all of this is very publicly available and really easy to read about. There are two parts to the UCSF dose measurement. The first asks you to look at doses in consecutive patients. It asks you to summarize the doses within particular anatomic areas, so in the head, chest, abdomen, pelvis, and spine. So we're not asking you to combine doses, because it doesn't make sense to look at doses to the head compared to the chest, but to look at doses in these four separate groups. You can summarize those doses using several different measures. We specify CTDI, DLP, or effective dose. And then you have to show the measures separately in children and adults, and we specify several different age groups of children. The second part of the measure is recording a measurement of dose in the patient's medical record. Very separate. Doesn't mean the dose has to be of a particular range. It just means you have to put it in the medical record. And in fact, in California, all of you in California who do medical imaging using CT should comply with this at 100%, because we now have a law in California that requires the radiation dose to be put in the medical record. So in terms of the measure specifications, the numerator means summary of the radiation dose within those anatomic areas, age, and machine strata. So you summarize the dose depending on what machines you have. If you have two different machines, one GE, one Siemens, you would summarize the dose separately for those machines. And then you'd look at the distribution and dose in terms of the average dose, the high dose, extreme doses. And within each strata you choose to look at, again, this is voluntary. You don't have to look at all strata, but within each strata or group you look at, you need 100 exams within that group, except if they're children's studies. And then the number was lowered to 50, because we don't usually do quite as many studies in children. And the denominator, and this is an important part, needs to be in consecutive CTs. So there's no choosing and picking which exams you want to summarize. You want to look at the doses in every head CT that you did within this particular time period and machine and so forth. In terms of the three measures, I'm sure all of you are very aware and comfortable with these measures, but CTDI reflects pretty much the average dose delivered through a single scan section, so this is a very valuable way to look at your doses. DLP, that's equal to the CTDI times the scan length, and so this is just the longer the scan, the higher the number. Effective dose combines the dose emitted by the machine, which is reflected in CTDI and DLP, by tissue sensitivity to developing future harm. And there are many ways to calculate effective dose. You can do them precisely or crudely, and gives, from my mind, an easy way to understand the patient's exposures across different kinds of tests, and therefore is very useful. There are many ways that you can collect and summarize your dose data. You can use any commercially available dose program, of now which there are many. You can actually, if you participate in the ACR dose registry, you can use those data to summarize the dose. And lastly, you can review your doses manually. I'm in no way pushing for this manual approach, but for some of you, this might be the simplest way to figure out what you're doing. I'm going to show you an example of that. We have developed a website to allow you, any facility, to upload your data and then see a comparison to other facilities' data and to complete a maintenance of certification process. And I'll show you a little bit about that. I will say that if you choose to participate in our dose registry, facility level information is kept completely confidential and data is anonymized as soon as it is uploaded to our website. And you should go to our MOC, our Maintenance of Certification webpage, for more information on what this involves. So we had a presentation at the RSNA this year. Jillian Keegan led this presentation that demonstrated the simplicity of using the NQF approach to assessing radiation dose. And what we did is we showed two ways of collecting data. One was showing that these data could be manually collected using the dose sheet from the PACS exam. So just looking at the data on PACS and writing down the numbers. The second way is we use an automatic approach using a software product that allowed us to do this as well. And then we are summarizing the results here for the RSNA presentation for 2 months periods, 2 years apart, to see what looking at those data can do for you. In terms of how much work it was to collect the data, obviously the manual approach was longer, but we estimated, based on 50 scans that we abstracted this way, that overall it would take about 24 hours of abstraction to complete this measure. The person who did this was a high school student, which means you could hire someone to do this in about a week, and you could comply with the measure and figure out how much doses you're using. The automatic approach, for us, we use a commercial software product, Radiometrics, e-exposure, to pull the data that we needed, and that took us very little time. It took us a matter of minutes to pull the data. So if you obviously have access to a commercial software product, that's the way to go. This is showing, looking at one of the categories, abdomen and pelvis, for 2 periods of time. The top is 2010, the bottom is 2012. It's showing, using DLP, that the dose over this period of time at our institution went down from just over 1,000 milligray centimeters to 676. So in this period of time, we saw a 34% reduction in dose. And this summarizing dose using this metric is a very nice way to understand how you're doing very quickly. This is using a different measure, but the same anatomic area. This is showing how we did in terms of effective dose using the IRCP weighting factors 103. And again, you can see on the top graph, the line showing the mean is then shifted to the left. The mean went down from 17 to 11 millisieverts. Again, a 35% reduction in dose over this time period. We looked at lots of different measures. The measure of SSDE, which I think is an excellent measure. It happened not to be specified when I submitted this NQF measure because it had not yet been developed, is a very nice measure, but for the purpose of looking at how you're doing, in our experience, it doesn't matter how you look. You learn the same things pretty much. So on the left is showing the 2010 SSDE and CTDI, and the right showing the same thing in the latter period, and both give very similar information. So for an individual patient, you may really want to look at SSDE to understand if your dose was optimized. But when looking at facility performance, which averages across all of your patients, the exact measure doesn't matter so much. You'll learn similar information from whatever you choose to collect. I want to show you a little bit about the audits that we're providing for people who choose to participate in the Maintenance of Certification project. And this is sort of using the NQF measure to give facilities feedback. And what this is showing is a summary of a site audit. And in this figure, which in this table, which is the first page of the dose audit, we're showing several different measures, such as effective dose, CTDI. We're showing for this facility how this facility, in 3 anatomic areas, abdominal, pelvis, chest, and head, compare to other facilities who are using the exact same machines. So in this way, we're not comparing people who have a new machine to an old machine or have some dose reduction software machine versus not. We're only comparing this particular facility to other facilities who have the same dose. And you can see we're comparing average and the range of doses. In the red highlighted cells, that's where this facility's doses tend to be higher than other facilities, significantly higher, and only cells that are significantly different are colored here, significantly higher in red for abdominal and chest. But the same facility in the blue cells is significantly lower in the area of imaging in the head. And so this dose report is a way for this particular facility to try to understand areas that they're doing better than average and areas that they're doing worse than average. And the column that shows that percent above the 75th percentile is a way to sort of get a gestalt, is the facility doing well? If the number above the 75th percentile is around 25%, the facility is doing average by definition. If that number is low, 2 or 3%, they're doing fabulously. And if that number is high, 40, 50%, they're doing less than fabulously. And the purpose of this is not to tell you which patients had a problem, but in general how you're doing. Some of the other ways the audit would look for the maintenance of certification is this one facility has a distribution of dose. This metric is effective dose at the top, showing that they have an average of a median, a middle dose of 9 millisieverts, compared to other facilities where the dose using the same machine is substantially lower, 3. So this highlights an area that this facility could explore what they're doing as a way to improve it. And we're also showing facilities how the doses on particular machines that they have compare to others. And this is a way to facilities to understand how they're doing and how to improve. So in summary, the NQF measure is a very practical method for assessing the radiation doses you use. I haven't gone into some of the nuances of what the pluses and minuses of the measure are. I think any measure can be improved, but I think as a starting point, it's incredibly useful. Manual data extraction is in no way the easiest way to go, but if you don't have any other way to go, I think it's worthwhile. I think there are many open source software products that we're happy to teach you about. You can email me personally, or commercial software products that can be used. Several of the vendors that have commercial products are displaying them at this meeting. I encourage you to go to look at them, because I think any way that you can look at how you're performing is a huge step forward in quality. You can use these data, once assembled in a meaningful way, to increase dose awareness, set meetings up with your clinicians, both within radiology and among doctors who order tests, to understand that we're delivering radiation. This is how much, and we need to do everything we can to minimize unnecessary exposures when possible. And then you can use these data as a jumping off point to try to improve how you're doing. And if you choose to participate in the UCSF dose registry, it will really allow you to compare the distribution to others. And if you complete a maintenance of certification project through us, you can get credit through the American Board of Radiology that obviously has wonderful financial incentives in terms of billing through CMS. And we're charging very, very little to participate in our registries. Our goal is to use these data to create new benchmarks and standards. Thank you so much for your attention.